Yes, we are live. And yes, we are live. Yes, we are live. So Chaitanya, just check. I've sent the YouTube link to see whether it's coming properly. And we have 13 people. So Shiva, I'm making you the host, and you can make me co-host later. You start recording after that.
Our screen share is not visible, Geeta. Apart from it, Geeta? Yeah, the shared screen is not visible in YouTube.
I have paused. Okay. Yeah, it is live on YouTube. Okay, good morning, everyone. Welcome to the Women's Webinar Series. So while people join in, let me just quickly introduce Niramai to people who are already here. So again, big welcome to this Women's Webinar Series. We are restarting this. Earlier we were doing once a month. We are restarting this with an excellent expert panel. We'll be talking about breast cancer, early detection, treatment, and none other than Dr. Mandeep Singh Malhotra-ji, a very, very well-known, reputed surgical oncologist from Delhi, Gurgaon, right now. So who will be doing the keynote address in a short while. While we wait for people to join in, I would love to quickly talk about Niramai, which is a startup based out of Bangalore. We launched in 2017, and we have pioneered this new technique for breast cancer called thermalytics. It's a novel AI-based test to detect breast cancer early. It's novel, because we have 32 patents, and we have probably we are the only company in India who's made a novel device made in India and approved both in the US and Europe, and several other countries. And we also happen to be the most awarded startup, be it a World Bank Award or a Commonwealth Award or the top 10 medical devices in Boston and Google Launchpad, and of course, National Startup Award. So we have developed this new method of detecting breast cancer called thermalytics, which can detect cancer much before a lump is felt and works for women of all ages, all breast densities, without any radiation, and completely affordable and accessible and portable device, where we enable this privacy-aware method of detecting breast cancer when nobody sees or touches the person. So if you want to know more about Niramai, please go to niramai.com. And you can also register for screening, book a home screening, or even if you want to conduct a camp, you can set your request. And our team will be very happy to support. Our clinics are there in 30 cities today, and many of some of the centers are even doing free of cost. Such as one of the Gurudwara centers in Gurgaon, for example. So with this, while people continue to join, it is my privilege and pleasure to invite Dr. Mandeep sir to deliver the keynote of today, which is on impact of early detection, breast cancer treatment and survival. Dr. Mandeep sir is like our mentor, and he has actually tried thermolytics test in the Gurudwara center, where they do so much of community service by providing this free of cost to so many women who actually benefited, not just in the detection, but also, continuing on to sort of treatment also. To do a formal introduction of Dr. Mandeep sir, I request my colleague, Dr. Charita, to come forward. Before I hand over, yes, hi, I'm Geeta, founder and CEO of Niramai. We are very, very glad to have you all. And please join every month in large numbers for this Women's Webinar series. And I really look forward to Dr. Mandeep sir's talk. Dr. Charita, for a formal introduction of Dr. Mandeep sir.
Thank you, Dr. Geeta. We all know that the month June marks the celebration and acknowledgement of cancer survivorship. It's time to honor and celebrate individuals who have faced cancer and emerged as survivors. So I welcome everyone who has joined us in support of this campaign, celebrating those who have fought the disease and those who are currently in the treatment. Let's listen more from the experts and a survivor sharing her journey. Dr. Mandeep Singh Malhotra is a skilled and dynamic oncologist with over almost 20 years of experience. He has completed his senior residency in surgical oncology from the prestigious All India Institute of Medical Science, Delhi. During his fellowship, he has worked in Broomfield Hospital, Shameford, UK. Also, he has got robotic certification for transoral surgery from UPenn, USA, hyperbariac medical technology certification from South Carolina, USA, molecular oncology certification from RGCC Global College, Greece. Among his various achievements, Dr. Mandeep has been awarded the Young Scientist Award. He is one of the pioneers in India for performing skin sparing or nipple sparing mastectomy with autologous reconstruction, prophylactic mastectomy with reconstruction for BRCA positive patients. He has wore multiple hats in his professional life. He is the Director Oncology of CK Birla Hospital, New Delhi, Chief Mentor for Art of Healing Center and Khalsa Cancer Care, Rajouri Garden, Gurudwara. He is a consultant to NABDH Germany for a project on breast cancer screening using visually impaired women. He has authored various articles, chapters, and blogs for both national and international journals, and has been an eminent speaker at many national and international conferences. It's an honor to have you as a keynote speaker, sir. Welcome you, sir.
Thank you for accepting our invitation, sir. Please request you to start. Sir.
Thank you, Chaitanya, and I express my gratitude towards Geeta ji and the whole Niramai team. I think this is a very great initiative of yours to increase awareness around breast cancer, both its treatment, its survival, the reason for early detection, and also post breast cancer. Like, as a issue regarding, so thank you for the kind introduction. So why breast cancer in particular? And this is something which is very important. As Geeta ji was telling about Niramaya and its startup concept, and also the awards it received. The issue is that breast cancer is the most common cancer which affects the women in India and across the world, and also now in India also it's breast cancer. On an average, we are expecting around 1.5 to 2 lakh new women getting breast cancer. And what is particular in Indian scenario as compared to the Western scenario is that over the years, not only has the incidence of breast cancer increased, but also the mortality due to breast cancer has increased in India. And if we look into the data says that if I particularly take the urban woman, it is 1 in 22, which is the lifetime risk of getting a breast cancer. And overall Indian population, it is 1 in 28. And again, only 50% of those survive breast cancer, and 50% actually is the registered number, which we have. Unregistered might be more, that they won't survive breast cancer. Whereas if we look into the West, though the number of the incidence of breast cancer is high, it is 1 in 8, but they have a survival rate of around 80%, which is in India, which is much, much lesser. And this is like the trends which we see, that how the increase in breast cancer has happened over the years. This is a very important graph which I want all of you to just draw your attention, particularly when we are talking about South Asia. So this is when we are looking at the peak age of incidence of breast cancer across different cancer registers in India. And what is common when you see across this graph is that the overall peak age of incidence of breast cancer in India is around 45 to 50 years. So this is a decade younger than what it is there in the Western population. And again, there is something very important in this graph, that when I'm looking at the Northeast Indian population, it's even much lesser. It is around 35 years when we are seeing the peak age of incidence of breast cancer in Northeast India. So this is again, as we can see, that the cause of death has increased, the survival is limited, and the last part is very important, that only 4% of our population is actually reaching cancer hospitals in stage 1 for treatment. Another important thing is that when we are looking at such young age of presentation, so the variety, so breast cancer has varieties. It has a hormone positive variety, it has a HER2 positive variety, it's a triple negative variety. So hormone positive is a good variety, it has better cure rates, we have hormone therapy to treat them. Whereas the other two varieties are the aggressive varieties. So when I'm having a much younger population, that is 45 is my peak age of incidence. So the triple negative variety is much, much higher in India as compared to the Western population. So this is again another important aspect when we are looking at breast cancer in India in particularly, that we have a younger age group, we have advanced stage of presentation, and the variety of breast cancer is also more aggressive as compared to the Western population. So these are the few important parameters which are contributing towards decreased survival due to cancer. And the only answer to this is early detection. There's nothing else which we can do. And early detection, as this is graph which you can see that how important it is, that if I detect a cancer early, so this is what I can achieve. I can have that 90% chance of survival. So basically I'm able to increase my survival, which is at this point of time just 50% to 90%. 100% probability that the woman will survive breast cancer with breast rather than without breast. Whereas in India right now, the data which I would say that which says that the number of women surviving breast cancer with breast is just around 15-20% or even lesser than that. And living without breast is also a huge impact which can have on women's psyche, its social factors, its economic factors. So that is also an important factor. And if I have a cancer at a much earlier stage, there's a 40% chance that I can treat that cancer without chemotherapy. So if the chemotherapy is not required, the breast cancer treatment actually becomes a cakewalk. It becomes as easy as doing a gallbladder surgery. So this is how important early detection is. And whenever we are talking about early detection, the first thought which is in our mind comes towards mammography. The important part of mammography in Indian context is something which we need to understand very clearly. What is mammography? Well, mammography is an X-ray of breast, and what does it do? It helps to note, identify certain changes which occurs in the breast tissue. But when we say when should the mammography be done, it should be done after the age of 45 years. So why this is so? The thing is that when the age is 30, 35, the breast tissue is mostly composed of milk ducts. And as the woman grows older, that is, she undergoes babies, lactation, then she's nearing menopause. So the milk ductal tissue, which is the ductal tissue where the cancer occurs, or the milk ductal tissue starts getting atrophied and it starts getting replaced by fat. And that is when we say that the mammography, when we click an X-ray or do a mammogram, we are able to identify a change. So if I have a 45-year age group female, so my incidence, my early detection has to start around 30 to 35 years. So at 30 to 35 years, mammography is not effective at all. Another important fact which is related to the Indian scenario, that is the Indian women, that is that 30% of our Indian women have actually more denser breast. So what does more denser breast means? That the milk ductal atrophy doesn't happen as what it happens in the Western woman. So that is the epidemiological character of the woman here. There's nothing wrong with it, but what it means is that mammogram again is not very effective to detect cancer at an early stages. Majority of mammograms which are happening across our country are diagnostic mammograms. What it means by diagnostic mammograms is that when there is a lump, when there is a discharge, then we are doing a mammogram. So this is basically we are confirming the diagnostics. When we are talking about screening or early detection, we are saying that we should do a mammogram when nothing is felt, and we should actually detect a cancer at a stage when nothing is felt, and at that stage when we are able to pick up the cancer, that is when we are achieving survival. At this point of time, yes, mammogram is essential, there's no doubt about that, but diagnostic mammography has its place and it will remain. But whether screening mammography is effective in India, that's a big challenge which we need to understand. Another important thing is that obviously the infrastructure, the accessibility, the affordability, the cost of a mammogram machine, the involvement of the radiologist, the human resource involved, again its accuracy. Then yes, doing a screening mammography also, it is not a very good experience. Then yes, there is amount of radiation involved in it, but yes, I'm not that's not a matter of debate, but it does involve some amount of radiation, which over the years the data doesn't say that it should not be it's that harmful. But the aspect is that the important aspect of our screening mammography part is that the applicability and effectiveness. So that is where there's no debate on that. That mammography as such, when we talk about screening mammography in Indian population, it's not that effective a methodology. Now, if I don't use mammography, what am I left with? We normally talk about clinical breast and self breast. Self breast is when the woman herself checks herself. So that is not something which generates confidence in women. They feel that whether they're doing it the right way or it's something which is right, or and it's not very compliant. The other is clinical breast. Clinical breast is when a doctor or trained medical personnel would check the woman at scheduled intervals. So obviously, at this point of time, our healthcare sector is evolving, and for healthcare workers to dedicate themselves for screening, we don't have that many healthcare workers who are doing it, and whether it's economically possible for them. So there's a big issue around that also. And when I'm talking about ultrasound, so ultrasound again comes, the issue around ultrasound is the infrastructure cost, the radiologist involved in it, and also there are certain factors according to the government rules in our country that it comes under the PNDT Act, or so we cannot make it as there are certain constraints to make it as available to all the public. So at this point of time, so what Niramaya is doing is something which is really great. So it's basically what? It's basically if I talk about in scientific terms, it's a thermography. So what is thermography is that it would detect, it's a IR camera which will detect any increased temperature. So any neoplastic process to start with, when the cancer is being formed or even at the pre-cancerous stages, the blood vessel formation increases. So when the blood vessel formation increases, so it's more angiogenesis, the more angiogenesis, it will generate more heat. So that is when it's being picked up by the thermolytic scan, which is developed by Niramaya. And the good part is that yes, it's so you do the scan, and then that scan is reported by an artificial intelligence. So this, the and the doing scan also is a very simple procedure. It's not as complex as doing a mammogram. And ultrasound again is a very user dependent procedure. So a technician can do it. It's a simple procedure, and an AI can report it. So the thing is that across ages it can be done. The cost involved is lesser. The cost of reporting is also lesser. And that is also an AI dependent, which over the years, as Geeta was telling about, will evolve, and it will become more accurate. So that is how it will evolve, and it's evolving. And this is a very good answer to this to the issues which in our country in particular, to solve the issue of breast cancer screening and early detection. So important aspect which I just wanted to talk about two more things before I end this thing. So when I talked about 100% probability of saving the breast, so the thing is that as the surgical procedures have advanced, so the concept of breast oncoplasty has come into it. So breast oncoplasty is successful in early stages. In this, either we reshape the breast and make a new breast and remove the lump. Like in this case, the lump is in the lower quadrant, and we remove the lower quadrant and reshape the breast into a new breast. In this case, the nipple is preserved. In this case, we took the muscle from the lateral part and make the new breast. In this, we took the muscle from the back and made the new breast. So this is how oncoplasty is more feasible in early stages. So cancer control becomes easier. The reconstructive or oncoplastic breast surgeries become more feasible in early stages of breast cancer. The last part which I want to come forward is, yes, the hereditary concept. As you can see the picture of Angelina Jolie. So when I'm talking about India, as such, so in black is the normal female which can have a breast cancer. The red is the hereditary component. And what happens with the hereditary component is that when I'm saying that 45 is my peak age of incidence, this data in India is not robust, but we are looking at around 20 to 30% of our general population to have hereditary breast cancer, that is hereditary breast ovarian complex. So apart from the lifestyle factors, the environmental factors, the chances that the cancer which runs in family are higher in India. First of all, it comes in younger age group. Secondly, this cancer is more aggressive. That is a triple negative heredity. So the thing I'm not want to talk about this, but what I want to highlight is that even if I have a family which has a high risk of breast and ovarian cancer, and they identify a BRCA positive gene, the important aspect is this, that the first part of this is again breast awareness. So when you talk about Angelina Jolie itself, so it was not that she had a high risk, she had a BRCA1 gene, so she got her prophylactic mastectomies at or prophylactic surgeries at much younger age. It is again 43, 42 when she underwent a risk-reducing mastectomy, and she was 47 when she underwent a oophorectomy. So the concept is that if there's a high risk, the breast awareness should be there. And how the breast awareness is, it should be a self breast and a basic scan. And at this point of time, I think that at high risk women also, the thermolytics is a very good option, because doing concepts like MRI is expensive. Mammography at younger age groups is not very applicable. And obviously, risk reducing mastectomy has not picked up in India in that way, because there are a lot of costs involved in it. So the answer towards it is a constant breast screening and awareness. and thermalytics can play a very good role in that, especially those who are having high risk family history. And what important is that in this group is that they have a 87% chance that they'll get breast cancer. They have a 50% chance that they'll get ovarian cancer. So for them to have a screening is very, very important. And this forms around 30% of the Indian population, which I would say out of 2 lakhs, if that is the sum, 50,000 of women would definitely need intense screening. And for them also, thermalytics is a good answer. It's just a picture how to do a risk reducing mastectomy. So the breast, skin and the nipple is preserved, and the fat and the ducts are removed, and a new breast is reconstructed. So thank you everyone. And I would just want to end with one note. I want to congratulate the Niramaya team for developing this technology, and because this I personally feel is an answer towards early detection, the lack of early detection in India. It's just not that we are always looking into early detection and we are attributing it towards lack of awareness. Yes, there are majority of India, the awareness is not there, but in parts of India where awareness is there also. So as I have highlighted, there are huge constraints to do early detection through the conventional methodology which is happening in the West. That cannot be reproduced here. So important take-home messages are that the answer towards breast cancer problem in India lies with early detection. There is no other solution towards it. The conventional methodology of mammograms is there, but it is not applicable towards majority of our population because we have a younger age group, we have triple negative. So in that case, the Niramaya plays a very, very important role because it can actually pre-screen. What does pre-screen mean is that you undergo a Niramaya scan, and this is a very highly sensitive technique. So even at the stages when any inflammatory process, any neoplastic process, any precancerous process is there, so it will increase the temperature and it will get detected in the Niramaya scan. So that is my personal experience. So you pick up that and then you do the radiology. So those patients who are negative with Niramaya, they are actually so that negative predictive value of Niramaya is very, very high. And that I really feel is the best thing for any screening process to have. Negative predictive value is that if I undergo a screening, I should be reassured that I don't have the disease. So if I'm reassured that I don't have a disease, so that is the best part of it. And then obviously if there is something I need to investigate it further, and yes, majority of times I still might not have a disease, but that is again, I'll investigate myself. I'll get those things done. Otherwise I would have never got those things done. And out of those high risk women, early cancers we'll be able to pick it up. So when I'm able to pick up these cancers, I'm able, the first of all is survival. Secondly, in country like us, if I have an early stage cancer, my treatment of breast cancer is 1/3 than when I have an advanced stage cancer, when the cost of treatment is 3 times more when I have an early stage breast cancer. So thank you, Geeta ji. Thank you, Niramaya team. And I really want to congratulate with what you have brought in for our country, and not even for our country, for the world, I would say. Thank you.
Thank you. Thank you so much for your kind comments. And of course, it's the whole Niramaya team. Thank you so much, sir. And thank you for the wonderful talk. And, I think, you covered both the early detection part and, what are the different techniques available, and also the breast oncoplasty part, which is the first time we are covering in this seminar series as well. So, of course, we open the floor to questions. But just to sort of seed, so just to sort of get everybody on the same page, sir, Dr. Mandeep, sir, in how many cases one can go for a lumpectomy, and breast conservation surgery is only possible at a lumpectomy case? Can you please shed light on what percentage of women may be able to conserve their breast, and how many percentage of women, what stage of lumpectomy and conservation surgery is possible, sir?
In early stage breast cancer, if the disease is of at single focus. It's not multifocal or multiple sites. Lumpectomy is the answer of choice. Every woman, a single focus early stage breast cancer should undergo a breast conservation rather than a mastectomy. The reason is not just breast. The reason is that in breast conservation, you have a lumpectomy followed by radiation. And now the latest data says that the women who have got treated with breast conservation tend to live longer than the women who have undergone a mastectomy. So survival is the key thing first. So at early stage, yes, lumpectomy or breast conservation should be done and is being done until unless the resources are an issue. In advanced stages, obviously, when we have more number of women with advanced stages, so breast conservation is not possible at that point of time until unless we give neoadjuvant therapies, bring the cancer down, and then do it.
Okay. Sure. Charita, are there other questions?
Yeah. Is there any age limit for breast cancer screening?
Age limit.
Upper age limit, maybe. I think that's what she means.
Yeah. The thing is that when I talk about standard conventional our protocols, we normally stop breast cancer screening around 75 plus. That is what we say. But the reason is not that we don't want to screen further. The thing is that until unless for a normal woman, a woman who is at in geriatric age group, the chances that she'll develop a cancer would be more of a hormone positive cancer rather than an aggressive cancer. So that is when we say that 75, 80, we can stop any kind of breast cancer screening. But yes, in that there's a caveat. If the woman is high risk due to family history, due to environmental factors, due to personal factors like being nullipara, having any hormone exposure, late age of menopause, or she's a smoker and all, the screening should continue. Yeah.
There is one more question. Is breast density associated with age? What are the factors that affect breast density?
Breast density definitely is associated with age. And breast, I just want to clarify one thing. Breast density is nothing wrong with breast density. So just to understand what breast density actually means is, as I was trying to talk about it, that when we say denser breast, we feel that what we mean to understand is that the milk ductal tissue has not atrophied and it's still there. So that is what it means by breast density. Normally in a woman's lifetime, when she is approaching menopause, so at that point of time, the breast tissue, the ductal tissue would start getting atrophied and it will start getting replaced by fat. So the breast from denser becomes non-denser. So this is normally what we have noticed. But when I say 30% of Indian women, the breast density doesn't decrease. So it's not a negative statement. It means that 30% of Indian women at the age of 45 can still feed a baby. So that is the inherent character of Indian epidemiology, Indian demography. So it doesn't mean that having a denser breast is something which is a negative part, but it's just that it just means that the screening methodology of mammography is not applicable. That's it.
Actually, I really like the way you said how dense breast is actually positive only for the lady. It's very nicely said, sir.
Yeah,
Because
actually,
there is this notion dense breast is bad. It's not. Of course, it's high risk, but
yeah, it's dense breast is high risk and all these things are there, but it doesn't mean that if somebody has a dense breast, so it means something wrong for her. For her, well, I would still what I'll tell you what exactly when I see it. So if a mammogram says that the breast is dense, so when we say it that, oh, at the age of 45 your breast still are 35.
you're much younger.
Yeah.
I have one more question. I think there may be more. We always talk about, cervical, at least there are, news about cervical vaccine, cervical cancer vaccine and so on. does it also address ovarian cancer? Because it was nice you were mentioning there. And so maybe just a bit about how, is there a way of taking care of ovarian cancer and any other women's cancer, if you want to shed some light?
So
sir.
cervical cancer is not related to the breast and any ovarian cancer. Cervical cancer is due to HPV vaccine. So cervical cancer is actually related to oropharynx and penile cancers. So that is habits and hygiene and virus. It's the breast and the ovary which are linked together. So when we say that somebody has a high-risk family history, so what is high-risk family history? We are particularly looking at family history of breast cancer. We are particularly looking at family history of ovarian cancers. So these breast and ovary are linked. If somebody has high-risk family history, it means that somebody has a disease mutation gene like BRCA1. So what is BRCA1? BRCA2, what does it? And again, BRCA1, BRCA2 is not something gone wrong with somebody. BRCA1, BRCA2 are actually what? It's a tumor suppressor mechanisms. So everybody of us, we get exposed to sun rays, we get exposed to pollutants, we get exposed to multiple things in our daily life. But our body has the inherent resistance or the corrective mechanism that if some thing goes wrong at the DNA or RNA, that is a mutation happens. So our repair mechanisms would go and correct those mutations, or they will discard that DNA. When some BRCA or when we say this kind of mutations are there, it's just that our repair mechanism is weak. So that is why our tendency to have a cancer is more. So when these cancers like ovarian cancers, the woman who has younger age group breast cancer, she can develop an ovarian cancer later on, or her family can have high risk ovarian cancer, and similar is for breast cancer. So what I mean to say when I say about all these things is that a high risk family history for breast and ovarian, they should take care of their breast screening, and for that thermolytics is a very good tool.
Thank you, sir. I think the last word is absolutely great. And are there any other questions, Dr. Charita?
If a woman found BRCA positive and her mother was diagnosed with cancer at 60, what age do you recommend her to start her screening?
Yeah. So if somebody is BRCA positive, obviously the first and foremost thing which she should start doing is that when she's aware of herself that she's BRCA positive and all, the 20-25, at least she can start doing self-test. Then if the so the screening after that, she should, when she's self-breast, she's doing self-breast every month, then she can visit her gynecologist once a year and ask her to have a look. And by 25 to 30, so that's a slightly gray area. By 25 to 30, we would say that she should start getting a routine breast screening in form of ultrasound or a thermolytics is a good example.
Hello. Hello.
Thank you so much.
So basically thermolytics, she can do it from any age. But 25-30 is something when we should recommend that she starts doing screening. And for that, either an ultrasound once a year or a thermolytic scan once a year is good enough. If something is noticed in that, then she should go for other MRIs and all. It's not that every year she should start getting MRIs. No, it's not like that.
I think it was an excellent talk, sir. Thank you so much for advising and guiding so many people on this call, and also this will be recorded, available for others to view. Thank you so much for answering all the questions very well as well. Is there any other question? If anybody else has any question, they can raise their hand or unmute themselves and ask. Okay. Thank you so much, sir. I know you're extremely busy and still took time to come in. Thank you very much, sir. Really, really appreciate it. Thank you, sir. So, right. So, so we now move on to the second talk by Dr. Rahul Raman. He's also a collaborator, excellent collaborator in the community screening from Renai City in Kerala. And request Dr. Charita for, to give a full formal introduction. And thank you very much again, Dr. Rahul, for agreeing to share your insights and knowledge about recent treatment advances in breast cancer. Charita, over to you.
Thank you, Dr. Geeta. Dr. Rahul Ravindra is an alumnus of Tata Memorial Hospital, Mumbai. He has almost 8 years of experience in oncology. He did his undergraduation from Xingzhang Medical University, PRC. He holds a diploma in radiotherapy from Amrita Institute of Medical Sciences, Kochi, DNB in radiotherapy from HCG Hospitals, Bengaluru, and DM in medical oncology from TMH, Mumbai. He has also acquired he is also a certified trainer in preventive oncology and also palliative care. He is specialized in comprehensive management of both solid malignancies and hematolymphoid malignancies. He has vast experience in organ preservation approaches and chemotherapy in the management of all tumors. He has worked in some of the best oncology hospitals in India, including TMH, Bombay, HCG, Bangalore, Rajgiri Hospitals, Kochi. Dr. Rahul is also an active researcher in the field of oncology and has almost over 45 peer-reviewed articles published in national and international journals. He is also member of various prestigious organizations like European Society of Medical Oncology, ESMO, European Association of Cancer Research, Indian Society for Medical and Pediatric Oncology, Indian Society of Oncology, and several others. It's our privilege to have you as a speaker, sir. The stage is all yours.
Thank you, Ms. Charita, for that wonderful introduction. And thank you, Niramay team, for calling me. Thank you, Dr. Geeta, for inviting me for this webinar. So I'll straight away start with my, session on, updates, recent updates in breast cancer. So let me just share my screen. Just a minute. Is it able? Are you able to see my screen?
No, doctor.
Mr. Dak, could you just share the slides for me? I have some problem pulling up my slides.
Yeah, sure. Is it visible, sir?
Yes, it is. So you can keep changing the slides.
Yeah, sure.
Could you make it full screen for me? Yeah. Next slide, please. Okay, so I have no conflict of interest, and I presume most of us would know what is cancer, and definitely it's one of a very dreaded disease, and just by simple terms, this is abnormal, uncontrolled, continuous replication of cells. So next slide, please. So if you could see, this is one of the most common cancer that you could find in India, especially in women, and 1 in 8 women will be diagnosed with breast cancer in their lifetime. It's not just women, it's even in men, though rare, but at least, compared to females, 1 in 138 men could get a probability of getting a breast cancer in their lifetime. Next slide, please. Yeah. So if you go by statistics, definitely breast cancer is increasing day by day. Every 4 minutes, an Indian woman is getting diagnosed with breast cancer, and a woman dies of breast cancer every 13 minutes. And we have nearly around 1.38 million new breast cancer cases that are being diagnosed every year. Next slide. So if you just look across India, if you take a lack of population, we have nearly 32 women who's getting diagnosed with breast cancer per year. And the highest would be in the state where I hail, that's from Kerala. We have nearly around 45.7 women per a lack of population who gets diagnosed with breast cancer, compared to UP and Bihar, which has a lesser number. Next slide. So let's see who is at risk of developing breast cancer. So I would take some cues from my previous speaker as well. We have certain risk factors, out of which certain things are there in our hand. That is a lifestyle, what we eat, where we get exposed to. Obesity is one reason, overweight, having an older children at first live birth or never having children at all, consumption of alcohol, and certain non-modified risk factors. That's like having a positive family history, or if you have a BRCA1 or 2 mutation, any previous history of radiation to the chest wall, an early menarche or late menopause. Next slide. So these things are quite common, and many of us would know it. But there are recent models that have come in oncology, but especially in breast oncology, where we are looking into do we have any risk estimation models? The Gale model was one such of it, but after that we have enough and more models which have in fact included multiple risk factors. It's not just the age, menarche, or age at live birth. Looking at the number of biopsies which is there, number of first degree relatives, second degree relatives, or third degree relatives, or someone who is having an ovarian cancer or male breast cancer in the family, or someone who has developed bilateral breast cancers. So people have incorporated multiple risk factors, and they have come up with risk estimation models. Next slide. So this would be something like a Gale model calculation, which would let us know that, who is at risk and what is your percentage risk of developing a cancer in 5 years. And this is something which I always get in my OPD, doctor, tell me what is my risk of developing breast cancer. So it's very difficult to say, but, most of the times I would love to use one of these calculators, which is freely available on the internet. And, this could let me know that, what is your average risk and what is your lifetime risk of developing a breast cancer. And compared to a normal population, how or at what heightened risk you are for developing breast cancer. Yeah, next slide. So we have enough and more of tools, when it comes to breast cancer detection. Definitely, we all know that we have a mammogram. We have evolved from an era of 2D mammogram to 3D mammography. And, now we have used computer-aided detection. People have started using, artificial intelligence basically for, detecting any kind of tumors, as you would see in the second images. We have dynamic MRI, where if you have an equivocal tumor, which you could see on an mammogram, you need to get more confirmation. Definitely, you could use an MRI for that. Again, we have a positron emission mammography, which just looks into the breast per se, and that is definitely helpful for lesions which is less than 1 centimeters in size, and molecular breast imaging, which is also coming up in near future. Next slide. So this is something new. This is something called as liquid biopsy. Now, of course, people are always worried about getting a biopsy, but this is going to come up in a great time in the near future. So all what you could say is that someone has a breast tumor. All these tumors are considered as a systemic disease. It always has a vasculature which is always nearby. And probably, once they start losing the adhesion, or if you have any changes in the adhesion molecules, that's when these cells start circulating in the blood vessels. And just a single blood test could help us to find out if there are something called as circulating tumor cells. And these circulating tumor cells would help us find out if someone is at risk of progressing during a time of taking a treatment. So in simple terms, if someone is having more than 5 circulating tumor cells, it's called as a poor risk breast cancer. So this is more like a prognostic test rather than a detection test. But there is again something which is coming up in future that's called as multi-cancer early detection assay. So MCED works on the same principle of liquid biopsy. Even before the tumor comes, you could just diagnose that you have a probable chance of picking up a particular kind of tumor. And the GRAIL is one test which is there in the US, Unfortunately, we don't have any tests as of now, validated tests as of now in India. Hopefully, we should get one of these tests in a near future. So people have conducted trials inside it, and they found like nearly 38% of the patients who were tested positive on this MCD test later on turned out to have a confirmed cancer at a later point of time. So the only flip side of this thing is that currently we don't have any guidelines to incorporate how we could use this MCEDs into detection of cancers. And the second thing is that these are highly sensitive tests. So even before the cancer, even if your mammography or your thermogram or any of these images could pick up these things, an MCED would pick it up on the simple blood test. And the only other problem is that it puts a patient at an immense risk, or probably at an immense heightened stress on waiting for which or by what time they're going to develop a cancer. Next slide. So we have come a very, very long way on the treatment of cancer. In 1894, that's when Halsted did a mastectomy for patients where he had removed the entire breast. And later on, they found that even after doing that, patients used to have disease recurrences. And that's when they came up with the hypothesis that breast is more like a systemic disease and not just a local disease. They tried using treatment with radiotherapy in the early 1900s. In 1940s, they started using chemotherapy for treatment of breast cancer. In 1980s, they started using targeted therapy in tyrosine kinase inhibitors or monoclonal antibodies. In 2010, they had started using checkpoint inhibitors, and later on in 2018, we have newer molecules like the CDK4 inhibitors and PARP inhibitors. So we are evolving in this whole journey of breast cancer treatment, right from surgery to targeted therapy. And we are fortunate to be in 2023 to see most of the evolutions of breast cancer. Next slide, please. Next slide, please. As I cited, these are the ways that you could treat a breast cancer. Definitely, surgery is a mainstay treatment. You could treat with a hormonal therapy if these are hormone-sensitive tumors. You could use a targeted therapy if these tumors harbor any kind of a HER2 kind of receptor mutation status. Many tumors require chemotherapy for treatment. And if someone is opting for a breast conserving surgery, radiotherapy becomes a backbone of treatment for breast cancers. Next slide. So this is just a snapshot on how you treat breast cancer. So if you have a localized disease or something like ductal carcinoma in situ, you just a surgery, a conservation surgery, and a radiotherapy followed by a hormone therapy, depending upon the hormone status. That's good enough. But as you go further, you start from your stages 1 and 2, where you definitely need surgery, chemotherapy for selected cases. If it's a breast conservation therapy, definitely radiotherapy. If you have a node positivity, you need to use radiotherapy. Or even if there is a tumor is more than 5 centimeters in size, you need to treat with radiotherapy. And depending upon the hormone status and depending upon the HER2 status, you use any of a targeted therapy or hormonal therapy. Going further, again, when you go to stage 3 and stage 4, it's more of a multimodality treatment where you use chemotherapy, surgery, and radiotherapy. And again, in a 4th stage, that's one area where you don't have much role of surgery, except if it is like a very fungating tumor, then probably toilet mastectomy is the role of a surgery, but otherwise it's mostly treated with chemotherapy, or targeted therapy, or hormonal agents. Next slide. So I won't be speaking so much about the advances in surgery, as my previous speaker has already, spoken about, breast conserving surgery and, the kind of plastic surgeries where they use. They try to preserve the breast. Of course, they could try to mimic and replicate to the opposite breast with the best of the best techniques. So I'll discuss something about radiotherapy and how things have evolved. Even though this has come way back in 1900s, people started using cobalt radiotherapy, which was one of a very crude form of radiation. So post-cobalt radiotherapy, people developed enough and more fibrosis on the particular breast. Even though they were able to preserve the breast, they found there's so much of fibrosis. The breast used to be very hard. So later on, they found that we need to evolve on the type of radiotherapy that's been used, and they evolved from that to 3D CRT, three-dimensional conventional radiotherapy, to an IMRT. And over the years, they understood that you don't have to use so much of radiation to treat breast cancer. You could actually increase per dose per fraction. So previously, they used to treat for 5 weeks, a 25 fraction radiation. And in 2012, maybe 10 years back, we had evidences telling that you could treat with just 3 weeks. And now we have good evidence that, you could even, bring down the whole radiation to just a week. Again, people have come up with newer techniques. Something they used to use something called as intraoperative radiotherapy or brachytherapy. Now they have come up with newer devices called as Mammocyte, the balloon device, which you could see. So where you could directly target the tumor bed with a high dose of radiation treatment. Yeah, next slide. So this is a very good question, which I always get, doctor, is there any way that I can avoid getting exposed myself to chemotherapy? Yeah, next slide. So to answer this question, we need to know certain parameters from or certain test results, what we would need. So one is that you definitely need to know what is your lymph node status. You need to know what's the type of tumor, what is the grade of tumor, what's the size of your tumor, and definitely the receptors. So there are certain receptors. One is an estrogen receptor. The other is a progesterone receptor. These two receptors are always seen in a lady. This is just related to the hormone, the estrogen and the progesterone, and the HER2 receptor. So HER2 receptor is always there in our body. It's a part of an EGFR pathway, but in certain women, in breast cancer cells, the HER2 can get mutated and there'll be abnormal accumulation of proteins of HER2. And if someone is having a HER2 positive disease, then we need to treat with an anti-HER2 agents. Next slide. So we have actually classified these tumors as per the molecular subtypes, where we look into ER, PR, and HER2. So if you have an estrogen receptor positive or a progesterone receptor positive tumor, and if it's HER2 negative, this is one of a very favorable tumor biology which you can have. So basically, these are good biology tumors where you have nearly around 40 to 50% of these patients having an ER/PR positivity. And then coming down the ladder is where when patients have a HER2 positive tumor, or we call it as a HER2 enriched tumor, where it's ER/PR negative. These are nevertheless good tumors. And the worst down the ladder is when someone has all negative, that's an ER negative, PR negative, and HER2 negative. This is something called as a triple negative breast cancer. And these are the types of pure tumor there where we have to treat aggressively, and the chances of relapse is quite high. Next slide, please. So to answer this question, do you need chemotherapy? So this is for a very specific subset of patients, where in patients which are stage 1 or stage 2, if they have a strong estrogen receptor positive tumor, and if they don't have HER2 positivity, probably you could do a molecular marker. It's called as Oncotype DX. And looking at a recurrence score, it just gives a score, what is the chance of recurrences. So if you have a low recurrence score, a score which is less than 17, it's just a cumulative score. If it is less than 17, then definitely you could avoid getting yourself exposed to chemotherapy. While if you have a higher recurrence score, it's always better to add chemotherapy in your treatment regimen. So this is one of a very novel test. And after that, we have different other tests that has come into the market. Apart from Oncotype DX, we have MammaPrint. Even now, recently, we have an Indian version of it, which is called a Scan Assist. People who have started using these tests to help us know that, if you are a high risk or a low risk, depending on which, where you could choose and tailor your treatment to take chemotherapy or not. Next slide. So even if you take, there is at least around a good 80% of patients who might require chemotherapy at some phases. So I mean, on different stages. So always I get this question, doctor, is there a way to avoid, hair loss? So I'm sorry for the caption, actually. So what I mean was that we have a kind of technique. It's called as cold cap. So all what you have to do is that you just have to set around 15-20 minutes before you get your chemo administration. You just need to cool your head. You just need to put this mask, this kind of scalp helmet over your hair. It cools your scalp. And by cooling the scalp, what happens is that it brings the blood circulation, it lowers the blood circulation to your scalp, thereby decreasing the hair fall. So this is one quite effective technique I have used. And I feel this really helps in many women, because, many women is quite concerned about hair loss. And in fact, many of them are concerned about hair loss. They may not be quite worried about the cancer. They're worried about the change in the physical appearance. So I feel this is one thing which has come up recently, and this could help a lot many of our patients. Next slide, please. So to put in a perspective, we have classified these tumors, which is like, the estrogen receptor positive tumors, the HER2 positive tumors, or the triple negative tumors. So depending upon the ER, PR, and HER2 status, we have actually classified these tumors as luminal A, luminal B, HER2, and basal-like. Next slide. So just looking at the statistics, out of 3, there are 2 women who would be having an estrogen progesterone receptor positivity, which is really good. These are very favorable tumors. And out of 5, 1 might be having the HER2 receptor positive. And nearly 10 to 20% of all breast cancers may be a triple negative breast cancer where they don't have any receptor positivity. Next slide. So going to these targeted monoclonal antibodies where we have used, this is the very first monoclonal antibody which people have used and tried, which is a time-tested drug that's called as trastuzumab, which actually works against HER2 positive tumors. So what I mean by HER2 is that if there is an abnormal mutation or a receptor mutation that has happened, and if there is abnormal accumulation of HER2 proteins in breast cancer, these kind of cancers are considered a poor prognostic cancer. And it's only after we have come up with this HER2 agent called as trastuzumab that the cancer survival has increased dramatically. So HER2 positive tumors do have a tendency of having distant metastasis. They might have brain metastasis as well. So with the advent of trastuzumab, things have started changing dramatically. And in the last 4 to 5 years, there were newer drugs where people have started, targeting the different HER2 domains, starting from HER2 1, 2, 3, and 4. They have come up with monoclonal antibodies called as pertuzumab. There's a drug which is called as a TDM1, which is having a chemotherapy backbone along with the monoclonal antibody. And they have used tyrosine kinase inhibitors, which is known as lapatinib, neratinib, or afatinib. So all these basically helps to control, cell growth or differentiation, and it helps to block the angiogenesis as well. Next slide. So the treatment options have actually changed from 1940s, where we found out the chemotherapy, to a current era where we have started using newer molecules, which is called as CDK4/6 inhibitors. The next slide. So the CDK4/6 inhibitors, I hope many of us would remember our cell cycle pathway, which we have learned in our biology lessons. So this particular pathway, we have targeted molecules where it would kind of block the pathway from G1 to S phase. So that's where the CDK4 and 6 is there. So probably if you could use any of these molecules to block the CDK4/6 pathway, you could increase the survival in patients. And we have come up with latest molecules called as palbociclib, abemaciclib, or ribociclib. So these are the molecules which act on this particular pathway. And this is absolutely beneficial for patients who are hormone positive, HER2 negative, metastatic breast cancer. And with the advent of this particular drug, patients who have a metastatic disease, who are exposed to abemaciclib, ribociclib, or palbociclib, you could find them having a median survival nearly up to 46 months. So that's nearly close to nearly 4 years of survival on a stage 4 metastatic breast cancer. And that is something which was unheard of before. So if you treat someone with only hormonal therapy, you could get a maximum of around overall survival of around 26 to 30 months. And if you are using one of these CDK4/6 inhibitors, you could reach up to 46 months. So next slide. So coming up next is a PARP inhibitor. So this is something which is used in treatment for patients who are having BRCA mutation positive. So BRCA1 and 2. So if someone is having one of these mutations, of course, everyone have a BRCA1 and 2 gene. So if at all this BRCA gene is mutated, that's when it predisposes to breast cancer. It's not just breast cancer. People can develop ovarian cancers. Of course, if it's a male, they can develop prostate cancer or pancreatic cancer or colorectal cancer. So multiple cancers are linked to this particular gene. And people have found out that, if you could target this by using an inhibitor called as a PARP. So it's called as poly-ADP ribose. It's a pathway inhibitor. So if you could use one of a molecule in targeting this particular repair mechanism, you could actually improve the survival of patients. And this is something which has come quite recently in the latest Olympia trial, where people have used PARP inhibitors in breast cancer, and they have found that there is improvement in survival. Next slide. So this is, of course, something which is heard quite recently, and it was just the last 2-3 years that we had some indication for using immunotherapy in breast cancer. So what I mean by immunotherapy is basically that we try to tweak your own immune system to treat tumor cells in simple terminologies. So tumor cells are something which is quite a brilliant kind of cell. What it happens is that we always have a very strong immune surveillance system, which is always linked to the T cells. We have the B cell and the T cell. So this is something that is linked to the T cells, and the tumor cells are quite tricky. It understands that the T cells are going to attack them, so it just wears a mask, and and it just sits in front of the T cells, and the T cells are not able to identify these are called as tumor cells. And they evade the T cell, the surveillance, and they start growing in our body. So by immunotherapy, what we try to do is that we try to just remove the mask. We just give the immunotherapy, remove the mask. The T cell understand that, okay, this is the target, and we can hit on this target. And this way we could actually kill the tumor cells. So recently we have come up with this drug called as pembrolizumab, which is an immunotherapy drug. This works in one of these very, very poor biology, the dreaded triple negative breast cancer, where we always had very dismal survival. Even though they're previously used in metastatic setting, now it has come up in a neoadjuvant setting also, where pembrolizumab works in triple negative breast cancer. Next slide, please. So the cancer treatment have actually changed over a period of time. Previously, everyone used to get surgery. A lot many used to get radiation. Everyone used to get exposed to chemotherapy, hormone therapy. Things have changed. The whole treatment paradigm has changed. We need to look at the prognostic markers. We need to look at the certain predictive markers. We need to look at the tumor biology, and then we have to decide a treatment for a lady. So no two ladies are treated alike. And the treatment in breast cancer have changed a lot. It's more a personalized cancer therapy that we offer these days to a breast cancer patient. Next slide. So it's, as I would say, the future is bright. We have actually come a very long way. Lots of new treatment options have come. But I would always tell to everyone, get screened on time. The earlier you pick it up, it may be you could just treat with a surgery and radiation, or probably hormone therapy. You could just avoid getting exposed to any of these newer drugs, or even in fact chemotherapy. So get screened on time every time. Thank you. I'm happy to take any questions.
Thank you very much for an excellent overview of such complex topics. You made it seem so simple. Thank you very much.
Thank you, Dr.
So do we have any questions already? So I'll start one. Basically, liquid biopsy, I think you were talking about it. And so one of the things that we hear is liquid biopsy may detect any type of cancer. You may not know whether it's breast or anything. So are there specific type of markers for breast you think the liquid biopsy can catch? Can you educate?
Yeah. So if you're looking into a perspective like, for diagnosis, then we still haven't come up with definitive markers for diagnosis. But if you know that someone is having a breast cancer and you want to look at the way that she's responding to treatment, or perhaps even before the scan picks up, a liquid biopsy could give us some idea about when they're going to relapse. That's where the liquid biopsy would take some role, but it's still nascent. I personally don't use so much of liquid biopsies for breast cancer. For certain tumor types I do. For lung cancer, it's a wonderful tool, but still breast cancer, we are yet to reach that target of where good potential markers we could use.
Thank you.
Is immunotherapy more prevalent in India considering the cost? And do they have recurrence coming in?
Yeah, so immunotherapy has come up off late. It has come up big in many cancers, especially lung, renal cancers. It has come up big time in recently. It has come up big time in triple negative breast cancers. So that's where in one cohort where we treat. So it's only just around 10 to 15% of the patients who are triple negative. And for them, in a curative setting, people have started using immunotherapy. The treatment would extend for nearly a year. I agree, it's quite expensive. It would cost nearly around 1.8 lakhs per cycle, and it comes every 3 weeks. it becomes ridiculously expensive. Not everyone can afford it. But people who are on health schemes, who are in any of the central government schemes or any government funded schemes, definitely they could afford this treatment. Or someone who has a very strong insurance backup, yes, they could. But if you ask me what is a percentage of people who take immunotherapy, I could tell this figures is just from the metros, from something from the physician's database. It's like around less than 5% is what patients who could afford immunotherapy in a current setting. And the chances of relapse, yes, nothing is 100%. So this is again something which would restrict to triple negative breast cancers. So there's something unique about triple negative breast cancer is that if they relapse quite early. They relapse in the first 2 years, and after that, every year the risk of relapse slowly starts coming down. So the risk of relapse is still there. This is never this is not 100% kind of cure molecule. Looking at the cost, that should not equate to the survival outcomes. Yeah.
What about endocrine therapy, sir? Is it part of the immuno, or is it related to?
No, endocrine therapy is totally different. So what I mean by endocrine therapy is similar as a hormone therapy. So if someone who is having an ER, PR, if you have a receptor positive, that's where you use the endocrine therapy. So you use drugs called as tamoxifen or letrozole, anastrozole. You use all these drugs, and this works well for patients who are in the luminal A, luminal B subset, who have ER and PR positivity. And for the latest guidelines or latest research which is shown is that you could use the CDK4/6 inhibitors along with this hormone therapy. That's where they have an added benefit. But people haven't tried using a hormone receptor positive tumor with immunotherapy. The whole idea is that it's basically in triple negative breast cancer where the maximum immune cells are there, and that's where the immunotherapy works. So people usually use it in triple negative breast cancer, and not it doesn't work well in a hormone receptor positive breast cancer.
So Charita, are there any other questions?
The
Hi,
last
doctor. Yeah, I want to ask one question.
Sure.
How do we personalize radiotherapy treatment plans to minimize the side effect while maximizing its effectiveness?
So, so radiotherapy is basically, you use X-rays for treatment for breast cancers. So these are X-rays. Previously, what they used to do is that they used to treat the entire breast and the axilla. Now it's more tailor-made that, you need to know that you don't have to treat everyone with axilla. Now, the problem of treating axilla with radiotherapy is that someone who has undergone surgery, they have removed the axillary lymph nodes. Now, if you're going to radiate the axilla, the chance of them developing a lymphedema, that's the swelling of the hand, is quite high as compared to someone who hasn't received radiation to the axilla. So just to give you some percentages, if someone has underwent an axillary clearance and then they have received radiation to the axilla, the chance of developing a lymphedema is nearly up to 30 to 34%. Compared to someone who is not exposed to radiation to the axilla, the chance of lymphedema will be around 15 to 18%. So we have now come up to a phase where we understand that you don't have to treat everybody's axilla. You just need to pick and choose who should be treated for axilla. So say, for example, someone is having more than 4 nodes, or if the axilla is not properly dissected out, or if someone is having an extra nodal extension, that's where we start treating the axilla fully, the level 1, 2, and 3 nodes. So that's one area where we, kind of tailor and we treat the patients. The other is basically the number of fractionations, what we should use. So we have started coming down the number of fractionations. Previously you used to go for 5 weeks, then we come out 3 weeks. Now we could treat for 1 or 2 weeks and we could finish it. But the less the fractionation, the other side is that, sometimes the breast cosmesis can get affected. So we need to understand if it's a young lady who is quite concerned with cosmesis, then try to increase the number of fractionations. Otherwise, if it's an elderly lady who is like 60 plus, she's not worried about it so much about the cosmesis, then you could give a fast forward kind of treatment and finish it off in 2 weeks or 1 week's time. Or you could use something called as breast brachytherapy, where the entire breast is not treated. You try to treat only the area, but of course, this is for a selected set of patients. You could treat with brachytherapy as well only to that particular tumor bed. That's also one way of treating it. And now people are using IMRT basically to reduce the side effects. Like if it's a left-sided tumor, the heart comes inside the field. So we try to reduce the dose to the heart so that they don't develop any cardiac events at data point of time. So people tailor make it, depending upon, what side of the tumor is, what is the stage of the tumor, and of course, what is the preference of the patient. So even radiotherapy is tailor-made. That's also quite personalized.
Talking about reducing side effects, sir, recently I was in an integrated healthcare kind of conference, and I saw results of a paper where they say, like, Ayurvedic medicine post treatment, right, during chemo or during after the radiation. They showed that it actually reduced the side effects quite a bit. Do you have any thoughts on that?
Okay, so this is a very
Controversial piece, yeah.
it's a very controversial area. So people have tried. I have seen these papers as well. Now I can tell you from my clinical experience is that I have people who have taken Ayurvedic formulations. But the biggest problem is that neither me nor they know what is the cumulative side effects. So I know that my particular drug can cause a little bit of liver dysfunction, but they may not be able to know what is the extent or what is the quantum of liver dysfunction that can happen when they're using a combination of Ayurvedic drug and my drug. So this actually hampers my treatment. And so I don't know. We don't have clinical trials looking into this Ayurvedic drug, which is telling what is the side effect. So if you have some data on it, definitely it's worth trying it. If one of these Ayurvedic drugs, if they could conduct a proper phase-to-phase 3 trial, letting us know that, you're using a particular kind of drug and this is the side effect profile of it, that will definitely help us, tailor our treatment, of course, definitely. But that's one thing which is lacking. And unfortunately, that's one thing which is lacking in from our Ayurvedic stream. I hope, they take things quite seriously and come up with, some data so that it will guide us through. And I always feel that, you should use all these forms of medicine, including Ayurveda and, our allopathic formulations for treating cancer. After all, if you look at all these chemotherapy drugs, these are all come from Ayurvedic herbs and things. All thing is that, we have just made it quite posh for using it for our patients. We know what is it with each drug. But I hope, the Ayurvedic counterpart, all those doctors would, take it quite seriously and come up with some of those clinical trials so that we can use it.
So nice. Thank you so much for that comment. Sarita, any other question?
Yeah, I think there are no more questions there.
Okay. Once again, let's thank Dr. Rahul for such a wonderful talk, and especially I again say it, you made it so simple. I know these are such complex cases and such complex decisions you make, because every treatment is different, for every person, right? So really, really appreciate going to the depth of many of these. Thank you so much, Dr. Rahul.
Yeah, thank you.
So I guess we come now to our very own Sabine, who's going to share her inspiring, fighting story. So, Dr. Charita, do you have a formal introduction for her as well? And Sabine actually heads our North American business development. It's an amazing, we started, of course, recently, but amazing passion of driving Niramay Thermolytics usage in US and Canada. So thank you so much, Sabine, for coming forward to share your story. Really, it'll be great inspiration to so many of people who fear cancer and who are just going through the cancer treatment as well. Please, over to you, and Charita for an introduction before that.
Thank you, Dr. Gita. As Dr. Gita mentioned, Sabine is originally from France. She holds an MBA degree from Watson School of University of Pennsylvania, and she holds BS in Mechanical Engineering. She had started her career in healthcare as a project engineer for a startup company, which was developing cartilage and bone repair products, as well as diagnosis equipments. She then became project manager for a packaging company, heading all the development projects in the US. After her MBA, she worked in financial industry for over 10 years, first as a trader for Citigroup, then in an alternative investment space. Sabine is now an entrepreneur. She founded her startup in 2016 that manufactures and distributes the award-winning Lift Me Up Bed Recliner, an innovative solution helping people with mobility issues and during her surgery recovery. She joined Niramay in 2022, and she heads the North American business development. Since her bout with breast cancer in 2014, Sabine has become very involved in the world of breast cancer and is very passionate about helping find a cure. She sits on the board of Manhasset Women Coalition Against Breast Cancer, a non-profit organization committed to raising awareness and funding breast cancer research. We are eager to listen to your story, Sabine. Over to you.
Thank you so much. And thank you to both doctors for giving such great presentation. I am going to tell you a little bit about my story, and then I will be happy to take questions. So in 2014, I was 41 years old, and here in the US, we are offered to start screening at age 40 with a mammogram. So I got my first mammogram at age 40 and went back a year later and got that phone call that there was something suspicious. So I had to go back, got a biopsy, and unfortunately it came out as positive. So it's always a shock when you hear, you have cancer. Luckily, mine was caught early. And it was a good type, the one that the doctor described. It's ER positive, PR positive, HER2 negative. So my prognosis was very good. So I did not panic, but the first thing that came to mind was, how about my family? How are they going to handle this? I knew I could handle it, but I was very worried about my family. So it's a DCIS diagnosis. And usually the way to handle it, like the doctors explained, is to get a lumpectomy. So I got a first lumpectomy. Unfortunately, we didn't get clear margin, which means that there were still cancer cells in the outskirt of the piece that was taken. So I had to go through a second lumpectomy. And again, we couldn't get clear margin. So that meant that I had to go to a mastectomy. And I actually elected to get a double mastectomy. So basically, instead of taking just the one breast that was cancerous, I elected to do both for different reasons. The first one was just I felt that it would be peace of mind just to have removed all breast tissue, because for me it was just a sign that something was wrong and I just didn't want to take a chance. The other reason is that here in the US, we are lucky to have access to a plastic surgeon that really gave me some great advice. And when you reconstruct, it's always more symmetrical to do both. So I decided to do double mastectomy. Now came the reconstruction part. So there are two ways of reconstructing, like the doctor explained, with your own tissue or with implants. I was not a candidate to reconstruct with my own tissue because I didn't have enough belly fat. So I had to use implants, but I really struggled with the idea, because when you remove cancer and then you add something to your body that is foreign, there's always risks. And it was really hard for me to make the decision. So in the big scheme of things, again, I was really lucky because my diagnosis was the good one, but I still felt like there was a lot of decisions along the road that I had to make that were stressful, and you plan for the long term. When you start, with a breast cancer diagnosis, you're on a journey, and it's going to be a lifelong, basically, because right now, so I reconstructed with breast implants, and unfortunately, 3 years later, I found out that they were recalled by the FDA. So they were creating another type of cancer. So here I was, I needed to have another surgery. So I waited a little bit because I didn't want to have back-to-back surgery. And 2 years ago, I exchanged my implants. And in the process, I actually requested a different way of reconstructing, because there's a lot of progress. I don't know if you could feel it from all the doctors' explanation, but so much is happening in the field of breast cancer, including reconstruction. And there's now a new technique. So instead of going under the muscle to put the implant, now they go above the muscle. And because I was in constant pain from my first surgery, I again asked my plastic surgeon to replace the implants above the muscle. It made a huge difference. So I'm 9 years out, and obviously 10 years is a big milestone for me, but I'm now pain-free from my reconstruction. And I have to say, I'm finally feeling like I don't think about breast cancer every day, although I'm very involved in the world of breast cancer, like I mentioned, and I can tell you a lot about what I'm doing. I'm helping a lot of women who are working now in my shoes, so I'm helping as much as I can. But it's been overall a very positive experience, as hard as it can sound. Breast cancer has changed my life for the best. And I'm happy to explain how the next question.
Thank you so much. I think really a fighter, I would say, like, because so many, one after the other issues, especially because of early detection, you were able to feed through it. So Sabine, what would be your message to people who say, I don't want to know whether I have breast cancer. I don't want to do the screening. So there are many such women in India who say, okay, there are many who are aware and they want to do the screening, but there are many more who basically say, I don't want to do that. What if I come to know I have breast cancer? What will be your message to them?
Yeah, I would ask them, please go and get screened, because knowledge is power, and catching breast cancer early makes such a difference. It really is a game changer as far as the outcome. I didn't mention, but I was lucky not to need treatment again, because we removed all the breast tissue. So I actually did not need radiation. I did not need chemo, and even drug therapy. I'm not under any treatment right now. And again, because I work with so many women who are going through breast cancer or have gone, and even taking drug treatment can have a lot of side effects and really be difficult on a daily basis, like joint pain, mood swings. And so really catching breast cancer early is critical. The Niramide test is painless. It actually, for someone like myself, who cannot get an MRI, well, I could get an MRI, but the cost is kind of prohibitive in the US. I cannot get a mammography, and the ultrasound are not really recommended either. So the Niramide test is basically the only test that really worked for women after a mastectomy, just to monitor myself, basically. And it's an amazing technology because it's pain-free and no contact. Just knowing that you are able to control the outcome, because if you get it early, again, you're going to have a surgery and minimize the side effects. So protect yourself, educate yourself, and don't be scared, because you have a lot of people who can help you, and you can talk about it. I think removing the stigma from having cancer. We don't choose to have cancer. I felt like I was eating very healthy, exercising. So you are not, choosing to have cancer. You are being a victim, and people are there to help you. So go get screened, and just have the knowledge of knowing that you're going to be okay.
Thank you. I think very well said. We don't choose to have cancer, but if it comes, we need to know how to fight it, right?
Yes.
I don't know whether there are any more questions, but I have one more. What would you tell to family of a cancer, cancer patient or a person who has just got detected with cancer, right? How should the family help them, or like, what is the best way for the family to behave with the patient?
Yes.
What are the good things that your family do?
Family support, friend support is critical. I was very lucky because I was, I had developed this amazing support group. Again, talking about it, leading the cancer patient should be leading the way, meaning that it's very important to respect, if she wants to talk about it or not, but offering support and showing that there's always somebody to listen to her. Obviously, going with the patient to all the appointments, it's very important, especially at the beginning, because you are under like such a shock that you don't really hear everything. So in the US, you have to make a lot of decisions. I'm not sure how it works in India, if the patient is really led toward different choices, but in the US, they just explain a lot of information, and then the patient really has to make all the decisions. So having someone there to listen in and just be there. I think also there's in my case, there was no family history. So it's something also that people have to understand. It can be something totally new that's hitting the families. So everybody should maybe just get educated And genetic testing is something that is available in the US. I'm not sure how available it is in India, but everybody, should get tested if they can, just to make sure that, again, understanding their risk if they become high risk is really critical. And talking to women who have gone through it, we have, that's what we offer through this organization that I'm part of, have a peer program where women can find someone who has a similar story. Everybody's different, every story is different, every journey is different, but if you can talk to women who have gone through similar steps or stages, the same type of surgeries or the same type of treatment, just to anticipate, understand, and be prepared. I think preparing yourself is really important. The power of mind over body is critical, so staying positive is really, really important. There's also nutrition, eating healthy, limiting your sugar intake, limiting your alcohol intake is really critical because your body's fighting the cancer, so you have to give it its best resources. Getting a lot of sleep, keeping exercising during your cancer diagnosis and treatment can really lower your stress. And lowering your stress, especially in my case, I thought was really, really critical. As soon as I feel too stressed right now, in this new stage of my life, I stop and pause because I know stress is really detrimental. So there's so many aspects that it's really a holistic aspect that you need to understand is a good way of controlling your risk against breast cancer. And I think against cancer in general, diet, exercise, sleep are critical to give the best to your body so that you are strong and avoiding risk for cancer.
Thank you. Thank you. I think these will be very, very, helpful to people. Yeah, I think there are more questions. Charita, over to you.
There is a question. Were you having any symptoms or warning signs of breast cancer?
Yeah, that's a great question. No warning signs, no pain, nothing. So again, my cancer was caught very early. So it was about half a centimeter. One thing I would say is that even though my breast cancer was not detectable by hand, I would really encourage every woman to do a self-exam on a monthly basis in the shower, just to make sure that she doesn't pick up on anything that changes. And having that discipline is really key because if you feel something, please address it, go and see your doctor, do not ignore it. Also, as a woman, I feel that we have intuition, we feel when something is different in our body. So even though you may not feeling anything wrong, if you feel like something is changing, address it, like stay aware and go and see your doctor. Don't dismiss it. One thing also I want to mention is that breast cancer does happen in young women. We talked about it, and unfortunately, I know way too many women who thought they were way too young to have breast cancer. So they were actually dismissed by their doctor when they first went because they had a lump. Oh, it's going to be benign, or it's just going to go away. But don't, let the doctors tell you that it's nothing. If you really feel something, please address it, and just really be in tune with your body.
What is your suggestion? Like, who is the women who should get screened? And if you could just give a lay summary of, breast cancer screening.
Yes. So again, I'm not totally familiar with the guidelines in India, but follow the guidelines. If you have access to the Niramai test, please consider taking it once a year. It really can make a big difference. Also, again, I mentioned that monthly self-breast exam, and as part of your annual checkup, again, I'm not sure how it works in India, but in the US, we have annual checkup with the OBGYN. So make sure to mention anything because breast cancer has different, it can manifest in different ways. You can have a change in the skin. You can have discharge from the nipple, obviously the lump, pain. So all these are signs that you should really get the doctor's input and be checked out. But again, just by yourself, if you feel that something is different, make sure that you bring it up with your doctor and stay on top of your preventative screenings.
Any piece of advice to people who are newly screened or who are undergoing treatment currently?
Yeah, I would say that, it's a very scary diagnostic. I totally understand that people go through a lot of different emotions, feelings. Some are angry, why me? People may want just to isolate themselves and just not, move. They freeze basically, and they don't know what the next step. And I understand that it may be even more prevalent in India, where there's a maybe stigma around having cancer, the cost associated with treatment. So I totally understand that. Here in the US, we are lucky because we talk a lot about it. We have a lot of group support. So I believe that there may be less stigma and people reach out, like there are lots of ways to reach out. But staying positive, like having positive thoughts about, knowing deep inside that you're going to beat the disease, because especially women, we are fighters. We here, for our family, if we have children, I know that was what was my main concern, is that my boys were 6 years old when I was diagnosed. I have twin boys. And I wanted to protect them and I wanted to be there for them. And that's what really, made me strong like a bull. And I was not going to let cancer just take over my fears or take over my life. So cancer is very disruptive. So when you do have that diagnosis, you have to stop everything and focus on it. I really, really ask anybody who unfortunately get that code to not delay any treatment, not delay anything. Please address it because time is really important. Again, my cancer was caught early, but it was an aggressive grade. There are 3 grades and mine was grade 3. So I knew that, it was really important just to act quickly. I was diagnosed in March, and by September, I was basically declared in remission and basically cancer-free. So for me, it was very short, 6 months. For women, it lasts longer because of chemo, because of treatment, but keep that positive mindset and surround yourself with positive people, and again, like good nutrition, meditation or yoga, anything that can really just protect you and give you that space where you're going to be able to find the resources and the energy in you to fight the disease. It's not easy every day. I again work with a lot of women, and there's a lot of up and down, but that's why having that support system is so important.
I think there are no more questions.
Okay, well, I'm here if anybody has any more question or anybody has need help. I would be really happy to help.
Thank you, Sabine. Thank you so much for sharing your challenges and struggles, and also sharing those valuable messages that you want to share out to people who are out hearing the talk today. Thank you so much for accepting our invitation and joining and sharing your story. God bless you.
Thank you. Happy to be here.
Dr. Geeta left, I believe. So